Happy New Year and welcome back to Count to 10. Today we're going to look at gas transport in blood, and this is the halfway mark of our respiratory physiology topic. We're now less than 2 months away from the first sitting of the primary exam for this year, and my goal is to try to get all the respiratory topics out before then. I also have a special podcast that I'm going to release 2 weeks before the written exam date with some tips and tricks on what to expect for the written exam. I'll break down how you can optimize your studying for the last 2 weeks leading up to the written date, what to expect on the date and how to get your peak performance on the actual exam date, and how to troubleshoot if things don't go your way on the day of the exam. Now, getting back to today's episode, gas transport is actually a deceptively important topic that gets asked frequently as SAQs and vivas. There's only 4 LOs that we'll cover today, and they include talking about the oxygen cascade, talking about how oxygen is carried and the oxygen dissociation curve, talking about how carbon dioxide is carried and the carbon dioxide dissociation curve, and then finally describing oxygen delivery and outlining the use of indicators for tissue oxygenation. As always, we'll cover SAQs at the end, both from the previous ANZCA exams and the ICU exam. So let's dive straight in.
1, 2, 3, 4.
Now the first LO today is describe the oxygen cascade. Examiners love to ask this in a viva setting, and you must be able to reproduce the graph from West instantaneously when you're asked. Essentially, the oxygen cascade is just describing the steps by which oxygen moves down its partial pressure gradient between the inspired gas in the atmosphere down to where it's used in the mitochondria. So the graph is typically an X and Y axis, which on the X axis has atmosphere and then all the way down to mitochondria, and on the Y axis just has the partial pressure of oxygen measured in millimeters of mercury. So depending on what text you read, there's 6 to 7 steps down that gradient, and the first step is the dry inspired air. So the partial pressure of oxygen here is simply the FiO2 times the atmospheric pressure. So this is 0.21 times 760, and this gives you 159, or if it's easy to remember, 160. The next step is that dry inspired air coming in contact with our airway. So remember last episode we talked about humidification. So here we have our saturated inspired air. So we have to take away our saturated vapor pressure of water. So we get the FiO2 times the atmospheric pressure minus the saturated vapor pressure of water. So that is 0.21 times 760 minus 47. So this is 149 millimeters of mercury, or easy to remember is 150. As that oxygen now travels down the alveoli, we get our next step, which is then calculated with our alveolar gas equation, which we all should know well by now. The F in the alveolar gas equation is just a correction factor, and you just have to know that for the examiner if they ask you, and it's typically very low, it's 1 to 2 millimeters of mercury. So with the alveolar gas equation, we get a partial pressure of oxygen of 100 millimeters of mercury. And the reason why it goes down from 150 down to 100 is twofold. The main reason is because we have the CO2 diffusing into the alveoli, so that's diluting the oxygen partial pressure as represented with the alveolar gas equation. But also we have a little bit of the O2 diffusing into the capillaries as well. So we lose a little bit of oxygen due to diffusion. The next step, which isn't quoted in all books but is quoted if you look at deranged, is pulmonary and capillary blood. So here, the difference is going to be essentially nil in a healthy person. So the partial pressure of oxygen is going to be very similar in a healthy person. And we'll discuss what pulmonary and capillary blood means in our next episode when we talk about VQ relationships. Following that, we get our arterial level of partial pressure of oxygen, which is lower and diluted due to the addition of venous admixture. Again, a term we'll talk about in our next episode when we talk about VQ relationships. But this is what gives us our normal AA gradient. So the AA gradient is the difference between alveolar partial pressure of oxygen and arterial partial pressure of oxygen. In normal healthy people, This is between 5 to 15 millimeters of mercury, and it normally increases with age as per normal physiological processes, but a large AA gradient can be used as a clinical tool to figure out what kind of causes of hypoxia we have in the patient. The next step down our oxygen cascade can be reversed depending on what diagram you use. I typically have the next step being tissue and capillary blood. So this is blood that's come out after being used in the tissues, and here our normal partial pressure of oxygen is quoted to be around about 40 millimeters of mercury. And the next step is the partial pressure of oxygen in mitochondria, so within the tissues itself. And this can be variable between 1 to 20 millimeters of mercury. And like I said, these 2 points can be reversed depending on what diagram you have. So just to recap, within our oxygen cascade, we start off with dry inspired air at approximately 160 millimeters of mercury. We go to saturated inspired air at 149 or 150 millimeters of mercury. We then go to our alveolar partial pressure of oxygen as per our alveolar gas equation. From there, we have our pulmonary and capillary blood, which has our partial pressure of oxygen, which is similar to our alveolar gas equation in a healthy patient. We then have our arterial partial pressure of oxygen, which has a normal AA gradient as per normal physiological differences, and that can also be worsened in pathological states. We then have our mean capillary partial pressure of oxygen, or our tissue capillary partial pressure of oxygen. And then finally, we have our partial pressure of oxygen within the mitochondria itself, which can vary between 20 to 1 millimeter of mercury. Now, with the oxygen cascade, there are 2 important points to note. Typically, you'll be asked, what is the Pasteur's point? Pasteur's point just refers to the critical partial pressure of oxygen at which aerobic metabolism can occur, and below that point, anaerobic metabolism has to occur. And Pasteur's point is typically referred to as being as low as 3 to 1 millimeters of mercury. So what that means is that between 3 to 1 millimeters of mercury, the mitochondria can still continue with aerobic metabolism. Below that point, anaerobic metabolism starts to occur. The second important thing with the oxygen cascade is that it's actually quite useful to help diagnose a problem in a patient. So you might be asked, what are the causes of low partial pressure of oxygen within the alveoli? If you know the oxygen cascade, you can then systematically kind of figure out that the issues must be either at the level of the alveoli, above the alveoli, so such as affecting the saturated inspired air, or above that level, affecting the inspired air. So the factors that can affect alveolar gas can be essentially summarized into those that affect the rate of oxygen transfer from inspired air into the alveoli, such as your degree of ventilation, the rate of oxygen transfer from the alveoli into the pulmonary capillary blood, so this is going to be affected by oxygen consumption, or the partial pressure of the oxygen that's been inspired, that's going to be affected by whether you're at altitude or what your atmospheric pressure is. So if you know the oxygen cascade well, you can figure out that if a problem occurs at one level, it can be due to that level or anything above that level causing a downstream effect. Now the next learning objective is discuss the carriage of oxygen in blood, the oxyhemoglobin dissociation curve, oxygen stores in blood, and their clinical significance and implication. Now, if I had to pick a learning objective that I had to know really well in respiratory physiology, this would be the one. To start off, we can talk about how oxygen is carried in the blood. Oxygen in the blood is carried in 2 main forms. It can either be dissolved, which is a super small amount, 1 to 2%, or it can be bound to hemoglobin, which makes up the rest of the way that oxygen is carried in the blood. Now, dissolved oxygen follows Henry's law, and Henry's law states that the amount dissolved is proportional to the partial pressure and the solubility of that substance. Oxygen, we know, is much less soluble than carbon dioxide, which is 20 times more soluble. The solubility of oxygen at 37 degrees is said to be 0.003 mils per 100 mils of blood per millimeter of mercury. So if we assume that the partial pressure of oxygen is 100, the amount that's dissolved is 0.03 mils of oxygen per 100 mils. This is a small amount when we consider that the total amount of oxygen in blood is approximately 20 mils of oxygen per 100 mils. So So like we said, it makes up that small 1 to 2%. Now there's two ways to increase the dissolved amount. We can either give the patient increased FiO2, and this is worked out using the alveolar gas equation. So if we give the patient 100% oxygen, we can increase that dissolved amount to 2 mils of oxygen per 100 mils. We can also manipulate the atmospheres. So if we put the patient in a hyperbaric chamber and say we give them 100% oxygen at 3 atmospheres, the amount that is dissolved can be increased all the way up to 6 mils of oxygen per 100 mils of blood. Now, examiners love this specific part because what it means is now you're increasing the dissolved amount past 5, which is usually the normal arterial venous difference of oxygen that a normal patient on baseline requires. So what that means clinically is that you can compensate for the oxygen requirement using dissolved oxygen alone, using hyperbaric chamber with 100% oxygen delivered to the patient. The other way oxygen can be carried is being bound to hemoglobin. And the way we calculate this is a simple equation, which is the amount of hemoglobin times the saturation of oxygen to that hemoglobin times the Huffner's constant. So there's a couple of important things there that you need to break down. The main question when you spit out that equation that you're asked is, what is Huffner's constant? Huffner's constant just describes the amount of oxygen that can be carried with 1 gram of pure hemoglobin, and that number is typically 1.39. You'll see that number being quoted as two different things. Sometimes it's quoted as 1.39 and sometimes it's quoted as 1.34. And this is again an examiner's favorite question to ask. The reason these two numbers is different is that 1.39 refers to hemoglobin only, while 1.34 considers that there is multiple types of hemoglobin within the normal patient blood. So there's hemoglobin, there's deoxyhemoglobin, there's carboxyhemoglobin, and there's methemoglobin. So if we consider there's lots of different types of hemoglobin, and not all hemoglobin is able to be combined or bound to oxygen, that number then decreases down to 1.34, which is the number we use clinically in our equation to calculate how much oxygen is carried or bound to hemoglobin. So if we plug in the numbers we know, the hemoglobin of a normal person, say being around about 140 to 150 grams per litre, the normal saturations being 100%, and the Huffner's constant of 1.34, we get that the amount of oxygen that's bound to hemoglobin and carried via hemoglobin is approximately 19 to 20 mils of oxygen per 100 mils of blood. So you can see proportionally it's a much higher amount. Importantly, this is the amount of oxygen in arterial blood. The amount of oxygen in venous blood is referred to as mixed venous blood. Mixed venous blood is blood sampled from the pulmonary artery. The amount of oxygen in mixed venous blood is 15 mils of oxygen per 100 mils of blood. So knowing that in arterial blood we have 20 mils of oxygen per 100 mils of blood, and in mixed venous blood we have 15, we know that a normal AB difference is 5 mils of oxygen per 100 mils. And this brings us back to the importance of the dissolved oxygen. If we were able to put a patient in a hyperbaric chamber and give him 100% oxygen at 3 atmospheres, we'd be able to make up that AB difference with dissolved oxygen alone. Now that we know how to calculate the amount of oxygen that's bound to hemoglobin and the amount of oxygen that's dissolved, we can put those two equations together and say that our total blood oxygen content equation is equal to the amount that's bound by hemoglobin plus the amount that's dissolved. The important thing with this equation is you never want to get caught out with the wrong units. So just be careful if you're using mils per 100 mils or mils per litre, and just make sure you're putting the right number in the equation to get the right amount. Now, before we get talking about the oxygen dissociation curve, or the ODC, we have to first talk about hemoglobin itself. Hemoglobin is a metalloprotein which consists of 4 subunits of polypeptide chains, so these are the globin part, and a protoporphyrin ring containing a central iron atom in the ferrous state, so ferrous being Fe2+, and this is the heme part. So each hemoglobin has 4 globins and 4 hemes. There are multiple different types of hemoglobin. There's hemoglobin adult, which is divided into A1 and A2. A1 is the most common, and this is hemoglobin that has 2 alpha and 2 beta chains. Hemoglobin A2 has 2 alpha and 2 delta chains, and you might see those levels increase in patients that might have thalassemia. Then we have hemoglobin fetal or hemoglobin F, which has 2 alpha and 2 gamma chains. And because it doesn't have any beta chains, it actually has quite significant implications on the ODC curve, which we'll discuss when we talk about the compare and contrast between fetal and adult type hemoglobin. The other important thing with hemoglobin is its shape. So hemoglobin is wrapped up into a complex shape which is bound together by electrostatic bonds between the amino acids. The shape has 2 key states. It can be said to be either in a tense state or a relaxed state. As the name suggests, a relaxed state is achieved when all the heme parts of the hemoglobin have oxygen bound to it, so it's nice and open, and a tense state is achieved when there's no oxygen bound to hemoglobin, and in this state it's hard for oxygen to come in and bind into hemoglobin itself. The reason this is important is that this is actually what gives the ODC its sigmoid curve. So hemoglobin has this property called positive cooperative binding. This is a key term that you must be able to say when you're describing the ODC. What positive cooperative binding describes is that binding of oxygen to just one of those heme sites induces a conformational change in the shape of the hemoglobin, which then allows an increased affinity for the next oxygen molecule. So in simple terms, what we're saying is that the binding of the last oxygen molecule, or the 4th oxygen molecule, is faster than the previous one. So each subsequent binding of an oxygen molecule increases the speed further and further. And that's why the ODC has a classical sigmoid shape. This is in contrast to myoglobin. Myoglobin only has one heme and one globin, so it only has one chain, and so oxygen can only bind to one spot, and therefore it won't have a classical sigmoid shape. So now let's actually look at the ODC itself and how to draw it. We've said that the shape is classically a sigmoid shape, and you put it on an axis where the y-axis is the oxygen saturation from 0 to 100%, and the x-axis is the partial pressure of oxygen. What the curve is showing is the relationship between partial pressure and the saturation of hemoglobin to oxygen. There are some important points that you must be able to draw and point out whenever you're drawing the ODC. The first point is referred to as the ICU point, and this is when the oxygen saturations equal 90% and the partial pressure of oxygen is 60 millimeters of mercury. What this flat upper portion represents is that across a wide range of partial pressures of oxygen, there's no big change in the saturation of oxygen until you get to this ICU point, and this is where we get a really rapid decline in oxygen saturations for a small decline in oxygen partial pressures. During this steep decline, there are a few important points. The first important point is mixed venous blood saturations, which is typically 75% and correlate to 40 millimeters of mercury of partial pressure of oxygen. The key thing with this point is that you don't draw it on your typical arterial oxygen dissociation curve. You draw it a bit right shifted because mixed venous blood will have a higher amount of partial pressure of CO2. So instead of 40, it will have 46, and therefore it will be right shifted. So that's just a key minor point that you just point out to the examiner when you're describing this curve. The next point is our P50 point. So P50 point describes what is the partial pressure of oxygen when there is 50% saturation of oxygen. And this is typically 27 millimeters of mercury. This point serves as a reference point to see whether the ODC is left shifted or right shifted. And the reason why we choose this point as a reference point is because it's in the sharp incline of the sigmoid shape. So any small change will represent a big shift in the curve, being either left shifted or right shifted. Following on, what are the factors that can affect the ODC? The easiest way to remember this is just to remember what you learned in med school. Remember you learned that if you were exercising, you would have an increase in CO2, your pH would decrease, your temperature would increase, and your 2,3-DGP would increase. Those four things would cause a right shift of our ODC. What does a right shift actually mean? It means that at the level of the tissues, we're having an increased ability to offload oxygen and a decreased affinity of oxygen. So we're increasing our offloading capacity, which is what we want at the level of the tissues, because we want the oxygen to be getting to where it's needed. And we're having a decreased affinity of that oxygen because we don't want that oxygen to be keeping itself on hemoglobin. On the opposite end, a left shift causes increased affinity of oxygen and decreased binding. And that is why a fetal hemoglobin, which is normally left shifted, is useful, because a fetus wants to have high affinity of oxygen. It wants to take the oxygen off the mother's hemoglobin and keep it for itself. A common effect that we get quoted here when we're talking about the ODC is the Bohr effect. And simply put, the Bohr effect is just describing that a decrease in oxygen affinity occurs with hemoglobin in the presence of a low pH or a high CO2. Finally, the last thing to know with the ODC in terms of the fetal ODC is the reason it has high affinity is because of its 2 alpha and 2 gamma chains. 2,3-DGP only can bind to beta chains. Fetal hemoglobin does not have this, therefore its shift to the left or right cannot be influenced by 2,3-DPG, so the resting P50 for fetal hemoglobin is approximately at 19 to 20 millimeters of mercury of oxygen. The other clinical aspect of the ODC that commonly gets asked is what happens to the ODC at altitude. We discussed this in our very first podcast, but it's quite a complex relationship, and it's varying answers depending on what texts you read, but my answer is based off nuns. And what the consensus from nuns says is that at altitude, the effects of a low CO2 and a high pH are stronger than the effects of an increased 2,3-DPG. So the predominant effect at altitude is a left shift of our ODC. Now let's look at our next learning objective, which is discuss the carriage of carbon dioxide in blood, the carbon dioxide dissociation curve, its clinical significance and implication. Carbon dioxide carried in blood is via 3 forms. It can either be dissolved, carried as bicarbonate, or carried as carbamino compounds. The important thing with carbon dioxide is that the proportion of each of these is different when you look at arterial versus venous blood. So in the arterial blood, the amount dissolved is 5%, the amount as bicarbonate is 90%, and the amount as carbamino compounds is 5%. In the venous system, the amount dissolved is 10%, the amount as bicarbonate is 60%, and the amount as carbamino compounds increases to 30%. The content of carbon dioxide in the arterial and venous blood is also different. So in venous blood, there's 52 mils of carbon dioxide per 100 mils compared to 48 in arterial system. And the partial pressure is also increased in the venous system, being 45 to 46 millimeters of mercury compared to 40 millimeters of mercury in the arterial system. The dissolved carbon dioxide just follows the same Henry's principle. However, we know that carbon dioxide is 20 times more soluble than oxygen, and so the solubility of carbon dioxide at 37 degrees is 0.67 mils per 100 mils per millimeter of mercury. Because the partial pressure of carbon dioxide is higher in the venous system, the amount dissolved is also going to be higher in the venous system. Carbon dioxide that's carried as bicarbonate follows an important chemical reaction that you must know. And this is that carbon dioxide plus water make carbonic acid, which then dissociates into a hydrogen ion and bicarbonate. Now normally, the first part of the reaction where a carbonic acid is made is slow. However, red blood cells have a large amount of carbonic anhydrase, which facilitates this reaction and speeds it up. Now once this reaction is complete, the 2 byproducts must go somewhere. So something needs to be done with a hydrogen ion and something needs to be done with a bicarbonate. The bicarbonate can freely diffuse out of the red blood cell. However, when it does this, it disturbs the electroneutrality of the cell because you're leaving a hydrogen ion that's positively charged with nothing to match it. So to maintain electroneutrality, a chloride ion shifts into the red blood cell, and this is referred to as the hamburger effect or the chloride shift effect. It's simply just to maintain electroneutrality. Because the hydrogen ion can't move out of the cell because of its positive charge, it needs to be buffered by something, otherwise it'll make the internal environment too acidic. Because it can't be buffered by anything outside the cell, the only buffer it has available is the hemoglobin, by binding onto the histidine residues of the hemoglobin itself. The last way carbon dioxide can be carried is by the formation of carbamino compounds. Carbamino compounds are formed when carbon dioxide combines with the terminal amine group of blood proteins to form carbamates. The reason why hemoglobin is a good protein to form carbamino compounds is because there's more hemoglobin present compared to plasma proteins. The hemoglobin structure is a tetramer, so remember it has 4 binding sites available for carbon dioxide to therefore bind. And when oxygen is not bound to hemoglobin, so when we have deoxyhemoglobin, the formation of carbamino compounds is greatly increased. So this leads us on to talking about the Haldane effect. We talked about the Bohr effect when we talked about oxygen, and the Haldane effect is equally as important when we talk about carbon dioxide. The Haldane effect describes the phenomenon where deoxyhemoglobin has an increased ability to carry carbon dioxide and to be a better buffer for hydrogen ions. And we think this occurs due to 2 reasons. Firstly, when there's deoxyhemoglobin, there may be a decrease in the ionization of the nitrogen groups, and so therefore there's increased ability to form carbamino compounds. And secondly, when there's deoxyhemoglobin, the pKa of the histidine residues changes, and this makes it more favorable for hydrogen ions to bind to hemoglobin and therefore be a better buffer. So when we describe the Haldane effect, we say that 70% of the Haldane effect is to improve the ability of hemoglobin to bind carbon dioxide as carbamino compounds, and 30% of the Haldane effect is to improve the ability of hemoglobin to act as a buffer for the hydrogen ion. Hydrogen ions come from 2 areas. They come from the reaction to form bicarbonate, and they come from the reaction where carbamino compounds are actually formed. The importance of the Haldane effect is actually quite immense. Without the Haldane effect, we would have a decreased ability to carry carbon dioxide bound to hemoglobin as carbamino compounds, and our partial pressure of carbon dioxide would be as high as 55 to 56 millimeters of mercury. So our venous pH would have a higher degree of acidemia. This would lead to downstream effects of disturbing enzyme function and normal cell homeostasis. Now let's talk about the carbon dioxide dissociation curve. What makes this so different to the ODC is that unlike the ODC, which is a sigmoid shape, the carbon dioxide curve is a linear curve. We again have the x and the y axis. The x-axis this time is the partial pressure of CO2, and the y-axis is the content of CO2 in the blood. So this can be mils per 100 mils of blood. Unlike the ODC, which you could shift to the left or the right, the carbon dioxide dissociation curve is shifted up or down. And we have 2 curves. We have an arterial curve and a venous curve. The venous curve is shifted upwards and slightly to the right, and the arterial curve is shifted downwards and slightly to the left. What this means is that for a small change in partial pressure between the arterial and the venous system, we can get a large difference in the amount that can be carried between the arterial and venous blood. And the reason for that is again the Haldane effect. So it's very important to be able to carry a lot of carbon dioxide in the venous blood without changing the partial pressure too much. Unfortunately, this is one of those curves that's the best description I can give. You just have to look at it and memorize it. And again, it's easily depicted in West. There's not much else that needs to be said with CO2 apart from knowing how to describe the Haldane effect well when asked in a viva setting. Our last learning objective is describe oxygen delivery and outline the use of indicators of tissue oxygenation, such as base deficit, lactate, mixed venous blood, and resuscitation. So we've already spoken about oxygen content previously. We said that we can figure out oxygen content if we know what the amount of oxygen that's bound to hemoglobin is, and we add this to the amount of oxygen that's dissolved. Oxygen delivery is an important equation. It's sometimes referred to as the oxygen flux equation. So the equation is cardiac output times the total oxygen content of the blood. Now, important thing is when you're plugging in this equation to make sure all your units match, and you should get a number that equals 1,000 mils of oxygen per minute. We can then also figure out what the oxygen content would be of the blood that's returning to the heart. So that's the mixed venous blood, because we know that the mixed venous blood partial pressure is approximately 40 millimeters of mercury. We know that the saturations are approximately 75%, and we can plug this into the same equation, and we should get 750 mils of oxygen per minute. If we take away the arterial from the mixed venous blood, we get a difference of 250 mils of oxygen per minute, and this gives us our baseline oxygen consumption in a normal healthy adult. And that's a simple but easy number to remember. People love to ask about the oxygen flux equation because they can go down any route in a viva setting. You can go down and ask about cardiac output, you can go down and ask about hemoglobin, talk about Huffner's constant, talk about saturations and a SATs probe. You can talk about the partial pressure of oxygen, Henry's law, compare this to carbon dioxide, or even talk about hyperbaric chamber therapy. The second part of this learning objective was to talk about the indicators. Now, there's no great indicator of tissue oxygenation in clinical practice unless we directly measure the tissue oxygenation at that level. So we have to look at surrogate markers to give us an idea of how the tissues are actually receiving oxygen and whether that's adequate or not. So we can take a step back and think about this at different layers. We can think about it on a macroscopic level. So is the patient or the person breathing a hypoxic mixture? What kind of altitude they're in, and relate this back to the oxygen cascade in the first couple of steps. We can then look at oxygen transport in blood. So what's the AA gradient? What's the saturations? What's the HB? And is there any pathology present? We can then look at the macro circulation and looking at the delivery of oxygen by looking at the patient's mean arterial pressure, or the MAP. We can look at cardiac output indices such as urine output, level of cognition, and GCS. And we can look at microcirculation through our clinical examination. So we can do a physical examination to assess for capillary refill, look for skin modeling, look at skin temperature, look for cyanosis, and then finally we can try and look to see whether the O2 is actually being used adequately at the cellular level. So we might do that by getting a mixed venous blood sample. We might look at our lactate in our blood to see whether there's enough oxygen, because lactate is a byproduct of anaerobic metabolism. However, none of these methods actually provide actual information of what's happening at the tissue level. These are all surrogate markers that we can use. Unless we can measure the tissue oxygen directly, we can't actually get the information we want. So we use all these surrogate markers to give us an idea of what we think is going on. So this is one of the learning objectives that just asks you to put all the physiological things you've learned into a clinical context and sees whether you can apply it or not. So now let's look at some short answer questions, and we're going to do this in order of the learning objectives we've covered. The first short answer that I want to look at is actually from the ICU exam back in 2015, and this is the one that you don't want to get caught out on. So in 2015 they were asked to describe the oxygen cascade in a person breathing room air at sea level. The examiner report was pretty straightforward. You needed that diagram for the oxygen cascade. You need to describe how the change in partial pressure occurred all the way from the atmosphere to the tissues. And the common error that was noted was that people usually forgot that in the alveolar, the partial pressure of oxygen decreases because of the CO2, but also due to the diffusion of oxygen. So structuring this answer would be very straightforward. You'd put that diagram in and you'd label it. So the diagram on the x-axis would have from the atmosphere down to the tissues. On the y-axis, you'd have the partial pressure of oxygen. The steps that you would have is the dry inspired air, saturated inspired air, alveolar gas partial pressure, pulmonary and capillary partial pressure, arterial partial pressure. Then you could have mean capillary partial pressure. And then finally, you could have tissue partial pressure or partial pressure at the mitochondria. You could then say at each level what the normal value was, how this was calculated, and then if you had time, you would talk about how these are affected or changed, And then in the end, you just have a brief statement about the pasture point. So the point at which the partial pressure of oxygen, at which aerobic metabolism can continue, and below this point, anaerobic metabolism starts. And this is variable in text between 3 to 1 millimeter of mercury. The next SAQ is about oxygen, and is from the ANZCA exam back in 2018, with a pass rate of 34%, making it a very high chance to be asked again. The question was, discuss the factors that affect O2 transport from the alveoli to the tissue. Now, reading it for the first time, you think this is a pretty straightforward question, but it's actually jam-packed. The examiner report here wanted you to talk about the oxygen cascade diagram. It wants you to talk about the alveolar gas equation, talk about Fick's law of diffusion, talk about the O2 flux equation, and then talk about oxygen dissociation curve. So I had a hard time thinking about how to answer this question, but I thought you could divide this question into 3 parts. You could divide it into and say there's a broad statement about the amount of O2 that's transferred from the alveolar to the tissues is determined by the amount of O2 in the alveoli, the transfer of O2 from the alveoli into the pulmonary capillaries, and then from the pulmonary capillaries and blood to the tissue itself. At the level of the alveoli, you would then go in and say that this is determined by the alveolar gas equation, and then break down each factor of the alveolar gas equation. And remember, when we talked about the oxygen cascade, we said that we could use that cascade as a good stepwise approach to figure out what is causing an issue at that step. So alveolar gas equation is going to be affected by anything that affects that equation. It's going to be affected by the saturated inspired partial pressure of oxygen, and it's going to be affected by the dry inspired partial pressure of oxygen as well. So then that's how you can try to incorporate the oxygen cascade into the question. The amount of transfer of the partial pressure of oxygen to the pulmonary capillaries is going to be affected by the Fick's law of diffusion. So you would put in the Fick's law of diffusion, and the main factors that are going to affect the rate of diffusion is going to be your diffusion barrier, the surface area, and the time for the diffusion to occur, so the speed of the blood flow through the pulmonary capillaries. Then finally, you would talk about how the transfer of blood to tissues occurs, and this is using the oxygen flux equation. So this is the cardiac output times the total amount of content of oxygen in the blood. And this question isn't focusing on the cardiovascular system, so you'd spend most of your time focusing on total amount of oxygen content part of this equation and factors that affect it. So things like saturation, hemoglobin, Huffner's constant, the amount that's dissolved. And then finally, the most important part for the transfer to the tissues is going to be the oxygen extraction at the levels of tissues itself. So these are going to be things like the amount of oxygen that's being used by the mitochondria, the partial pressure of oxygen at the level of the tissues, the carbon dioxide at the level of the tissues, and other factors that are going to shift our oxygen dissociation curve and cause either an increased transfer or a decreased transfer. So here you could put all the factors that cause a left or right shift of the ODC, but you would clearly state that the biggest factor of oxygen delivery at the tissue level is going to be mitochondrial use, because that's what's going to cause the biggest extraction of oxygen off that hemoglobin so that it can be used at the level of the tissues. So this is a really tricky question, and it's one that you have to really pick and choose your battles of what you think is the most important part. If I personally had to choose to leave a part, I wouldn't really talk about the oxygen cascade. I would talk about the alveolar gas equation. I would talk about diffusion, and I would talk about the oxygen flux equation. And then I just put that last fluffy line to say, like, at the level of the tissues, the amount of oxygen that's being used by the mitochondria is the biggest determinant of tissue extraction. Then, back in 2019, in the ANZCA exam, we were asked to draw the oxygen and the carbon dioxide dissociation curves on the same axes and compare and contrast these two curves. We were also given a variant of this question in 2022 first sitting, when we were asked to draw the ODC curve for both fetal and adult hemoglobin and explain why these curves are different. The key in these questions is to clearly read the question. In 2019, they pretty much stated what they wanted on the X and the Y axis. They wanted a partial pressure versus a content graph, and people got marked down if they put a partial pressure versus saturation graph. And this was clearly stated in the examiner report. The other common problem they said was the graphs were not drawn well. which is a absolute no-no when it comes to these graphs. These are graphs that you should know really well. The answer itself is not very hard. What you need to be able to do is draw the graph as they've said. So on the x-axis you would have the partial pressure, and on the y-axis you'd have the content. You know the content numbers for carbon dioxide being 48 and 52 arterial and venous blood respectively. You know the arterial and venous content of oxygen, 20 versus 15. And you know those important points that you need to put for your ODC. So those are your P50, mixed venous blood point, and your ICU point. You can just make two tables for these graphs, and this should cover everything you need to do in that answer. The first table is going to be a simple compare and contrast of the oxygen versus the carbon dioxide dissociation curve. So you can say that the partial pressure is 100 versus 40. This is in the arterial system. You can say what the content is, you can say what the AB difference is, and you can say how oxygen and carbon dioxide are stored or carried. So oxygen is carried by hemoglobin and dissolved, and carbon dioxide is either carried by being dissolved as bicarbonate or as carbamino compounds. Then you can make another table which has a comparison, and you can compare the shape of the curve. So you can say the O2 curve is sigmoid while the CO2 curve is linear. You can say the slope of the curve, so you can say the O2 curve is shallower while the CO2 curve is steeper. You can say what changes the curve, so O2 curve gets either left shifted or right shifted as per the factors that increase when you exercise, so things like CO2, temperature, 2,3 dpg, and a change in hydrogen concentration. You can say the CO2 curve either moves up or down based on the Haldane effect. You can say that there's distinct differences in the O2 and CO2 curve. So the O2 curve, the clinical implication is the flat upper portion acts as a buffer, while the CO2 curve, any small changes in the partial pressure will result in a big change in the content. And then the other implication is that a change in minute ventilation will greatly impact CO2, while a change in minute ventilation will have minimal impact on the O2. When you look at the other SAQ that asks us to describe the difference between the ODC in an adult and a fetus, the main thing to note is that you would again draw that same curve. You would again say what the main points are, and you'd again have a table of the main things being the slope, the P50, what changes the curve left and right. The key thing you want to say is that the fetal hemoglobin has no beta chains, it has gamma chains, and this has an effect on the 2,3 dpg. 2,3 dpg can no longer bind to the fetal hemoglobin. Fetal hemoglobin therefore has high affinity. And the last key thing you would state is actually what the curve is doing. So the increased affinity by the fetal hemoglobin actually meant that for any given partial pressure of O2, fetal hemoglobin has a higher saturation. And this increased hemoglobin oxygen content for any given partial pressure of oxygen, together with the increased hemoglobin concentration that the fetus has, results in adequate oxygen delivery to the fetal tissues despite a low overall partial pressure O2 environment. And that last line is literally taken from the examiner report. Apart from those couple of questions, there hasn't been too many other specific questions that have been asked about oxygen content and oxygen delivery from the ANZCA exam, but there have been a number of them asked from the ICU exam. So I'm going to quickly run through them. In 2018, in the ICU exam, they were asked to describe the carriage of oxygen in blood, including the total oxygen delivery per minute. This question was very simple as per the examiner report. You just need to divide the carriage into dissolved and that bound to hemoglobin. You would explain dissolved by using Henry's law, and you would describe the amount that's bound to hemoglobin using the equation Huffner's constant times the hemoglobin concentration times the saturation of oxygen in blood. You would explain the principles of hemoglobin and how it has positive cooperative binding and how it has two states, relaxed and tense. And then you would just write out your oxygen flux equation, which is the cardiac output times the total amount of oxygen content in blood. The key thing you don't want to get wrong there is putting the wrong units, knowing that your end result is going to be 1,000 mils of oxygen per minute as the amount that's delivered to tissues. Then again, in the ICU exam in 2015, they were simply just asked to explain the ODC and the factors that may alter it. Then moving on, in the ANZCA exam in 2019, we were asked to describe the way CO2 is carried in blood. They love this question and they've asked it 3 times previously. The last time they asked it, the pass rate was 65%. There's not much to add about this question apart from what the examiner report already stated, which was you needed to discuss the way that it was dissolved, the way it was bound to bicarbonate or as carbamino compounds. You would talk about in dissolved Henry's law. You would talk about in bicarbonate the equation water plus carbon dioxide forms carbonic acid, which then dissociates into hydrogen ion and bicarbonate. And there you could mention the hamburger effect or the chloride shift, and you would always mention carbonic anhydrase. And then finally, with the carbamino compounds, you would mention that carbon dioxide reacts with terminal amine groups to form carbamino compounds, and that subsequently an hydrogen ion is produced through that as well. The reason you say that is that you don't forget when you're describing the Haldane effect, that the Haldane effect is 70% increased ability to form carbamino compounds, but 30% effect for hemoglobin to be an improved buffer and carry hydrogen ions. And this is because the pKa of the histidine residues changes and increases. Then the last SAQ that we have is again from the ANZCA exam, and it was asked way back when in 2004, where the question was, describe how CO2 is produced in the body. How does it move away from the site of production to the pulmonary capillary? The examiner report here wanted some specific information, mainly the site of production of CO2, the amount that's produced, the mechanism of production, the transfer down its concentration gradient, the mechanism of the carriage and the amount that's carried, and then extra marks were gained for the Haldane effect. So you could start off this answer with just some simple facts and say that the amount of CO2 produced per minute is 200 mils. It's a byproduct of aerobic metabolism, not anaerobic metabolism, and that it's actually produced in the mitochondria by the citric acid cycle. So in the citric acid cycle, there's 2 molecules of CO2 produced per ATP. Additionally, if you wanted to be fancy, you can say that CO2 production will vary via substrate. And remember, this relates back to the respiratory quotient number, which describes the CO2 production divided by the O2 consumption. And we said that with carbohydrates, this is 1, with fats, this is 0.7, and with a protein diet, this is 0.8, and with alcohol, this is 0.66. You can then say that CO2 will move out of a cell down its concentration gradient, and this will follow Fick's law of diffusion, and you could describe the factors that would affect this. So a higher CO2 production would lead to a higher gradient and a faster diffusion, and that the solubility of carbon dioxide is much higher or 20 times more higher than oxygen, making it better at diffusing across a cell membrane. Then you can talk about the carriage in blood dissolved as bicarbonate or carbamino compounds, and you can say in the venous system we have deoxyhemoglobin, and due to the Haldane effect you have increased ability to carry carbon dioxide as carbamino compounds. And again, here you can put some numbers in, so you can say the Haldane effect is responsible for 3.5 times more carbamino compound production. And that's pretty much all you need in that answer. And that concludes the SAQ section of the podcast. So just to quickly recap, we've covered a lot in today's podcast. We started off talking about the oxygen cascade, and we said it was a partial pressure gradient of oxygen all the way from the atmosphere down to the mitochondria. We said that there were some important points to remember, such as the alveolar gas equation and Pasteur's point. And then we also said that the oxygen cascade was useful in figuring out if there was a problem and backtrack to figure out why there would be decreased partial pressure of oxygen at a certain level. Then we moved on and talked about oxygen itself, and we said that oxygen is either carried dissolved or bound to hemoglobin. We said that the important property of hemoglobin was its ability to display positive cooperative binding, and this is why the ODC has a sigmoid shape. We said that there were some important points to remember with the sigmoid shape of the ODC when you're drawing it, such as the ICU point, the mixed venous blood point, and the P50 point. We then contrasted oxygen to carbon dioxide and said that carbon dioxide is carried either dissolved as bicarbonate or carbamino compounds. Both oxygen and carbon dioxide have unique features. Oxygen has the Bohr effect, while carbon dioxide has the Haldane effect. Both are important at shifting and increasing the ability to carry oxygen and carbon dioxide respectively, and how these factors actually work. Finally, we spoke about the oxygen delivery equation, or the oxygen flux equation, which is commonly referred to in questions, and it describes that oxygen delivery is equal to the cardiac output times the total amount of oxygen content in blood. So this would be the amount that's bound to hemoglobin plus the amount that's dissolved. In the amount that's bound to hemoglobin, we spoke about the Huffner's constant and why this number is different in different texts. So like I said at the start, this is a deceptively important respiratory topic, and it's one of those respiratory topics that you have to know really well that kind of ties in the whole of respiratory physiology. Next episode, we'll be back talking about VQ relationships, and that's going to be a jam-packed episode, and we'll have that special podcast 2 weeks before the primary written exam with some tips and tricks. Until then, good luck with your studying, and thanks for listening.